139 explain what a drug reference is. So if that was it, was looking at references, just like books, source books.
Julia, isn't that your understanding? When we talk about drug references, what we had listed was like, what's the PDR and what are the online resources to reference your drugs? We weren't teaching about what is an actual drug reference in terms of approving, the FDA approving drugs and that kind of thing.
Yes, absolutely correct.
Okay, good.
So we need some new verbiage here.
Yeah.
Julia, are you willing to work with me on some new verbiage here?
Yeah, I can do that.
Okay. Okay, perfect.
So you could probably combine 139 and 140 when you work on that.
Okay. Okay, that is the end of pharmacology. We're going to move right on to administration of medications through injection. Describe universal, explain how to utilize.
Okay, so hold on. You use the word describe when often what you mean is define. So if I'm defining a universal precaution, that's what you have right there. If I'm describing universal precautions, I'm saying things like I would wear a mask and I would wear gloves and I would use, so define is what you've done there. So okay. Then your next one, explain how to utilize, there you go. That would also be a describe. And when you're writing competencies, those terms are very specific. You probably have learned that through the years of doing this. So.
Well, I guess not, Holly, because I
I wasn't going to say anything. But, all right, so sterile
words, Holly.
Spike. What on God's earth is a sterile spike? Is it for infected vampires?
I don't know. It's what they told me on the web. I don't know.
Yeah. So these
sterile
things.
Spike refers to just spiking a bag.
Exactly. It's the built-in little thing. So this isn't for medication administration. These particular things are about IVs. And so each different kind of route of administration has different things. So list equipment needed for medication administration, based on route of administration might be the question, and then they need to know that. So each one has its own little list, starting with often with a, well, not for oral, but maybe a little alcohol wipe, and then, for IVs, it's a pretty long list, longer than that. Because you got the IV bag, you got the catheter, you got the blah, 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 blah. So, so those answers are not answers that are going to work.
Do we need those listed?
That's a good question. If we want to, we could. They definitely make easy. They do make good listing questions, but they don't make as good a multiple choice question.
So,
well, since I'm already working on the language for the routes of administration, I'd be happy to work on this if we want that listed.
How's that? Okay.
Yeah.
Perfect.
What do people think? Do we want it listed?
I mean, I teach it, but I teach it when I'm talking about like when I'm talking about those particular skills, like when I'm doing injectable meds or when I'm doing IVs, I like list the equipment that you need for that, or like when we're doing suturing, we list the equipment that you need for that. So like when I'm teaching, I lump it in with those portions of LD&D instead of it being like a separate thing.
Yeah. It makes sense to me to create the lists, Des, and maybe add them to our skills test. the list of supplies that are needed for the skills test.
Yeah.
Because it's really hard to, I mean, you can do it. You can say things needed for an IM injection and then list everything except chainsaw or whatever, you know, but it's hard to ask them in any significant way. And it's kind of, they have to know it for skills. So I like that idea, Julia, of working it in there.
Okay. Okay, 2.4. Explain the different needle sizes, length, and bore needed for medication administration.
So again, it depends on how you're administering it, whether it's subdermal, sub-Q, or IM, or if it's obviously an IV. So that you're going to need help with from somebody.
Are you familiar with this?
Who are you asking?
Greg?
I bet Greg knows all about needle lengths, sizes, and bore.
Very familiar.
Greg, would you like to help me on this one?
Sure, absolutely.
And
So it's based on the different type of administration, is that what you said?
yeah. So an IM needle is on an adult is at least 1.5 inches, but on a newborn, it's going to be shorter. And if it's sub-Q, it's a different, you know, depending on the med. So Greg knows all the ins and outs of it. So.
Perfect. Greg, you and I will work on that then.
And then a filter needle, these days, we don't, it's not a device at the base of a syringe needle. It is its own needle that has to be put on and removed before you put on the needle you use to inject. It does filter the little tiny pieces of glass.
So how would you like my entry on this one?
I can send you a definition of that. I mean, there are two kinds that you can get, but the kind that you're describing here is hard to get and more expensive.
Okay.
So I don't know anybody who uses them. I haven't seen one even. Greg, do you ever see these kind of filter needles where it's built in?
Not built in, it's always a separate needle.
Yeah, me too. I don't know that I've ever seen that in the real world. So
2.6. Again, would this be the same kind of thing I need to work on with Greg?
yeah. And I can just tell you, Greg, that we use down to a 1 mil syringe for like epinephrine and sterile saline, and up to a 10 mil for, although not usually, for lidocaine. Most people use somewhere between a 5 and a 10 for lidocaine. So 10 cc, yeah, for lidocaine.
The one, so you're good with that, Greg?
Sure, absolutely.
Okay. Okay. Anybody have any?
I'm going to read through it and send you some stuff. Most people just use for a skin disinfectant and alcohol wipe. For purposes of administering their trials. Because this isn't about bladder irrigation. This is just about wiping down the injection site. You did a great job, Cynthia. A great job.
Oh, goodness. Okay, what about 2.8, Holly?
Oh,
Or-
no. I just need everybody.
Yeah.
I would say this is way more detailed than we're ever going to need to know.
Okay.
I personally didn't know that the type 1 glass containers were 80% silica. So
Could be.
different kinds of glass.
Yeah, think like multi-dose
Yeah.
vial, single dose vial,
Yeah.
ampule.
Glass
Much-
ampule. Yeah, that's what we're
Yeah.
looking at, Annie.
Who
Do
would
you
like
Way
to
less
work on
detail.
reduction of this with me?
sound like Julia wants to?
Are you signing me up for things, Holly? Yes, sure. I'll help you with this. Sure.
Okay.
Although this is super interesting. I've never read this before. 4 types of glass containers. Holy moly. Who knew?
Okay, so 2.9.
So this is that.
Yeah, this is what
Yeah.
we're.
This is that.
What is this? Is that means? I'm sorry.
2.8. This is what we want in 2.8. Glass ampules, multi-dose containers, single-use vials.
2.8. So this 2.9 will go away?
Yeah, but not the content. The answer is right there for 2.8.
Yeah.
What they're used for is to hold medication. So
Yeah.
I'm not sure what the
So
answer to that would be.
2.9's question can go away.
Okay, perfect. Okay. And then, okay, let's talk about dosage guidelines. Again, this is,
It's already up above. It's already in 1.4.
We already did this, yeah.
okay, because I wasn't sure if because we're on the IV section, if we needed to duplicate it specifically for, because it's repeated in every section. So we will take out the dosage guidelines here. And same with 2.11, explain what the guidelines are for
Yeah.
injection. Yeah, go away.
Yes.
Okay,
We've
and then,
already, I mean, it looks like because we already did this up there.
Yeah.
so 2.12 we'll take away.
Mhm.
Okay,
Yeah, and 2.13.
Yeah, that we've already discussed all of this.
yeah, it's repeated in every section. Now, what about 2.14? I don't think this one is added,
No.
asked anywhere.
And we do define the different routes. Let's leave it alone for now. We'll have to renumber, but you're going to have to renumber everything anyway when you reformat.
Mm-hmm.
I would say that goes under administration sites, possibly.
Yeah, it's more of a site thing.
Mm-hmm.
Yeah, when I talk about it with the needle length and bore, because like the size of the needle that you're using for the neonate is different than the adult.
Right.
But I guess I talk about those things all with injections at the same time. So we talk about injection sites. So, yeah.
But not the dose. Dose doesn't go there. The dose is up above.
Oh,
Correct. It should
So
just
explain
be
how to differentiate
the
intramuscular
intramuscular technique.
The main thing is newborns, you can only use one, the safest single, there's only one site that's considered standard and safe for newborns. The technique is actually the same. It's just the smaller needle and,
Yeah, so maybe it should say differentiate the site and equipment for intramuscular injection or something.
yeah, so under administrative sites, I think we can move 214 down because we have 214s.
yes.
And it's not, and again, not dose. Dose is not related to technique in general.
So 214 goes away, the first 214 altogether?
Yeah.
Okay. Okay. And or how to explain how to differentiate the site and equipment for intramuscular
Injection of,
and then what about the answers?
I keep hearing Julia volunteer. It's like her little voice just keeps saying, I'll do it.
This is Desi. I'm happy to add that to my list.
We'll add Desi on this one. How's that?
Julia's like, thanks a lot, Holly. Appreciate you noticing me.
Hey, I'm
Okay.
signing up. for
Okay,
other
so what
things.
about 2.15?
Okay, so there are 4 basic answers to 2.15. dorsogluteal, dorsal ventral, deltoid, and whatever the other one is, lateralis, which I can send you or any of us can send you. But 2.16, that is not a thing.
Holly. So Holly, I'm going to put your name here, okay?
And you spell that Julia?
Yeah. That's funny. Okay, so 2.16 is not a thing?
Is that a thing? I mean, the only way in which it's a thing is that certain sites can only accommodate a certain amount of milliliters of medication, but we're not working in those quantities. So I don't think that's a thing.
Okay, we'll delete
Yeah,
that
it's
then.
more about like which medications are suited for administration. It's not about the injection site. Like
Exactly.
Pitocin is given IM, so it's only suitable
So
for
there are
those
4
injection
sites to
sites.
choose from. Exactly.
Right. So
Do we want, so we don't want to leave 2.16?
No, gone.
no.
Okay. 2.17?
No, these are not sites. These are
Right, how did-
modes, and they're not even modes of administration. They're types. Well, the first 3, well, all 4 of them are types of ways of injecting medication into the body, which we call parenteral, if I'm remembering correctly. These are, maybe what you want to do is define the 4 parenteral routes for administering medication. And at least the 4 you care about.
Yeah.
Does that sound right, people? And then
Yeah, I think that sounds good.
That's good.
and then we just need to define them. So whoever wants to define them, I'm happy to define them if nobody else wants to step up. Since I'm on 2.15 anyway.
Colleen, I haven't heard
I'm
your
happy
name
to
in a
do it.
while.
That's true. I'm not super voluntary right now, am I?
She hasn't been.
How about I get that from Colleen?
You got to spell my name right if you want me to participate.
Oh, no, yes.
Oh, wow.
Sorry.
There's a long board history of that. That's why I said it.
I could tell that there was some story there.
Uh-huh.
I know how to spell your name. I just missed it. Missed that extra.
That was a typo. That was totally a typo.
Totally a typo. Uh-huh.
Okay, what about 2.18?
We just
We
have this
already
above.
talked
Isn't that this? Yeah, that's the same one as 2.14.
Yeah, we did.
So get rid of 2.14. Yeah, just get rid of that.
We changed the wording.
I know from
Right,
what.
but it's
Or-
the
So
wording is
241
on 2.14. This is like
I'm sorry, Julie,
Justin.
what?
this is like almost an exact duplicate of what 2.14 was. We don't need it a second time.
Okay, we added in equipment, didn't we? And so which one is better, I guess is my question. 1.8 or 1.4?
Oh, maybe it
We
was
don't,
1.4. It was earlier, maybe.
well, we added in an equipment because of the different length of needle and that's as much about
Yes.
the weight. I mean, yeah.
So am I
Yeah.
eating 1.4 or 1.8?
1.8.
Delete
Yeah.
1.4. Yeah, 1.8. Keep 1.4.
1.8.
And instead of explain how to, the way don't you can't, we're not explaining how to differentiate. We are differentiating. So just differentiate the site and equipment.
Okay. Okay, moving on to
Yeah,
point
that's-
checks.
Yeah, the 3-point check technique.
The answer is in 2.20.
Yeah.
0.20?
The
answer-
below it is the answer.
Yeah.
Well, you can say describe, you can say the 3 points are date, type, and dosage, so that's the 3-point check. And then when you perform it is when you get the medication to draw it up, after you've drawn it up to verify, and before you've injected it. And then actually there's 4 times you check, which is after you've injected it, just when you're charting it. So
Holly, you're going to provide me some language?
apparently so.
Perfect.
And she spelled my name right, so I can't even say no, I can't do it because I don't know who that person is.
Okay. 2.20.
Same thing, I'll help you with that.
Okay. Okay. 2.21.
So these are the ones that are going to be covered on our exams, our skills exams. So for IM, for subcute, and we also have intradermal, intradermal for our sterile saline. I mean, our sterile water, sorry, brain part. So for those, my thinking is once we have those templates for the exams, the skills exams drawn up with the list of supplies and the steps and everything super outlined, easy for somebody to administer, we can share that information with the students. It's not big mystery because they're not going to cheat off the test. You know, it tells them exactly what we're expecting in the order we expect it. So we can just say, C, 4 steps, C, IM injection, whatever we're going to call it, test for now.
And what was this one? What did you call it?
Intradermal.
ID.
Dermal.
ID. And same with 2.2, the new 2.24. Appropriate care of equipment used.
So this depends on if you're talking about, depends on how you're talking, what kind of medication you're talking about administering. But what I'm trying to wrap my brain around what the answer to this is. Appropriate care. So you make sure it's still sterile. The packages aren't open. Like, what are we looking for here, do you guys think?
Colleen, I couldn't hear you.
I mean, yeah, I don't know, expiration dates on some things, but that's rare. I'm not sure what the purpose of this question is.
I don't think we're going to ask about it, so I don't think it should be in the.
Yeah, it's more applicable to like IVs where you're like storing fluids and those sorts of things.
So
Yeah.
everyone good with me deleting this? Okay.
I mean, we cover what the temperature range is, I believe, up in 1.4, don't we? Like it can't be frozen and all that stuff. So that's what they need to know about. Because in terms of, I'm pretty sure you can keep a syringe and needle set in your car for just about any temperature, and it's going to be fine if there's no medication in it, as long as it hasn't expired and isn't open. You know? So I don't know that we need to go into. All right. So practical applications. If this is the competency guide for the written exam, I would separate this out and have these are not going to be helpful to somebody unless it's in these are the things you're going to be tested on your skills exam.
That's what this is.
Okay. So filter needle with glass ampoule will be included, multi-dose vial will be included. IM injection on a very muscular grapefruit will be included, subcute. I don't think we do need to list anything there unless we want to say see the exam for what they need to know. because we're going to ask them, at least when I do it, they use a filter needle on a glass ampule for an IM injection, then they do a subcute, then they do on a grapefruit. So basically, mostly I'm looking at the angle and the needle that they're using, and then an intradermal, which is very hard to actually do on a grapefruit because it turns out their skin is quite a bit thicker than ours. You don't get a bleb at all, but
You could use a tomato.
you could.
Okay, a little, nope, that's the same thing. Just drop down a lot.
That's funny. I'm having a tomato for lunch, and as I picked it up, I said, "Hey, you could use a tomato."
No, we won't use that tomato, okay? So sterile water and papules, Corinthia, are the intradermal.
Oh,
It's the only thing we do intradermal.
so what would you like me to do?
So we're at 2.28 instead of sterile water papules, just say demonstrate intradermal injection.
Take administration out?
No, yeah, demonstrate, yeah. Just like the others say above it.
Okay, but it's intradermal?
So get rid of it, administration of, and sterile water.
Well, my document isn't working here. So we'll retype. Dermal?
Intradermal, yeah, DER injection.
Yeah, sorry, I can't get it to delete.
It just doesn't want to do it. It's having a little moment.
Yeah, I'll just write a note. Okay, so that is the end of 2.0. So treatment of shock. So define the pathophysiology of the
So
type.
hold on. This is all going to need, so shock is a list of the symptoms of shock, but shock is a condition resulting from inadequate perfusion. That's the definition of shock. And it's characterized by all of those things.
Condition of what?
Inadequate perfusion.
And because of that, you see, depending on where you are in the shock cycle, an increase in a fall in blood pressure. And then you also have caused by, and then you have a bunch of, so we'll work on that.
So I'll just put your name by this one, Holly.
Yeah.
Yeah.
I've done a lot of work on this, so I have a lot of stuff.
Okay.
Pathophysiology of shock. The others are tissue perfusion. So we'll work on this section to get it squared away
Okay.
on both of those.
Okay.
Four types of shock. Distributive, anaphylactic. Well, anaphylactic is not one of the types.
Yeah, it's under.
These are not correct. So it's hypovolemic, distributive, restrictive, and cardiac, I believe.
Yeah, I list hypovolemic, distributive, cardiogenic,
And restrictive. So restrictive is like embolisms and
oh yeah, obstructive. Obstructive is the word.
Yeah, or restrictive.
Yeah,
I'm call both things.
What? Obstructive?
Obstructive / restrictive. This is one of those things where people, differ. But neurogenic is not an anaphylactic or type. They fall within these other four types. So, but if you look this up on the internet, I'm not surprised that you saw this because that's an old way of, some people still do it that way, but they're wrong.
So I can leave the hypo and the distributive. We'll take out the anaphylactic and the neurogenic and add cardiogenic and obstructive, restrictive. And so I'll just get information for these two.
Yeah, and if you want me to, I'll work with you on this one too.
Okay.
I'm all about shock.
Okay.
Shocking.
Okay. 4 cellular phases.
We call it the 3 stages of shock because, you know, I usually leave out the initial, but what do you?
She has the 3 phases below in 3.5.
Yeah, so I don't think we need the 4 phases of cellular phases of shock as long as we have the 3 phases of shock, because we're not looking at this on a cellular level. And so what I need to know is that people recognize where they are in the shock cycle and that they're doing the appropriate thing, not that they know what's happening on the cellular level. So I vote to remove 3.4.
Is everyone good with that?
Yeah.
And then
Yeah,
3.5.
that's accurate, absolutely.
This is what we need. And so I can review this to make sure, because I haven't looked at this in forever, to make sure that looks right. But that's what we call them: compensated, uncompensation, and irreversible.
Okay.
Use your DRT unless a miracle occurs.
Okay. Signs and symptoms.
And here I would divide it into compensated and uncompensated potentially. What do people think about that? Or is that too much? Again, for me, it's all about recognizing where you are in the cycle and taking, sometimes people kind of normalize falling blood pressures in a way that makes me very nervous. But again, not a hill I want to die on.
Conference is now ending. Goodbye.
So do you want to separate it in compensated and uncompensated, did you say? What are your thoughts?
I don't have strong
I
feelings
think
about that.
it's a lot, but I think the ability to recognize compensated shock, particularly in the newborn, is vitally important. But it's, again, not a hill I'm ready to die on either.
Yeah,
I'm sorry, what, Colleen?
I feel the same way. I don't think it's critical. I think whatever is going to help people recognize this progression as quickly as possible.
I do think it's helpful to know the difference, especially for people that are doing this initially. But again, I don't have strong feelings.
And some of these things, white and pink frothy sputum is not a sign of shock. It's a sign of respiratory, involvement, like AFI or something. Like, so some of these are a little bit. So we'll have to work on this too, Cynthia. How about if I break them down, and then if people think it's too confusing, we can combine them.
Okay.
Everybody
good with that?
Ankles might need to come out as well.
Yeah, exactly. This needs a little work.
Okay.
It's not much different than just listing it in order of severity. So
It kind of is, yeah. Although there are changes, like blood pressure goes up and compensated and goes down and uncompensated, and pulse goes up and then it goes to hell, So there are differences, and I definitely will separate out low blood pressure issues from pulse issues because they're, I already have this somewhere, Cynthia, so it'll take us but a moment to get it done.
Okay. Patient assessment.
So one of the things that we do is, the way we teach it is, and the way I explain it to my students, because they're not used to thinking about it this way, is more of a kind of a medic's way of looking at it, as in when you come onto the scene, quote, scene, what are you looking at? And hold on, I have some notes here. I thought I had out, but I did not, because bad me. So when you come, let's say you walk into the bathroom and she's laying on the ground, right? What are you going to look at to make sure that she's, what are the first things you're going to look at? And so we call that, because we're clever that way, primary survey, right? So you're looking at her level of responsiveness, her airway, breathing, and circulation. And then I teach it a secondary survey, and Greg, speak up if this is like I'm on drugs or something, but this is all the other specific vital signs, the history, the situational stuff. But when you first come across somebody who you think is in shock, you're always looking to see, and I think about it as when we learn CPR, it's like, are you okay? Are you okay? Call 911, make sure there's an airway, do the breathing. That's what you do when you first assess somebody who you think is in shock, especially if you come on to them. And then you do all of the others, the secondary survey, the pulse, the blood pressure, the respirations, pupils, temperature, pallor, capillary, all the other things that you're going to check. So that's one way to approach this to help people organize what they're doing. Now, the reality is we don't often come on to people laying on the ground in the bathroom, although that could happen for sure, or the kitchen or wherever they are. So if we want to teach it in another way as just signs and symptoms, we could totally do it that way.
Is anybody opposed to primary, secondary, or do we want to keep mental, vital, and other?
Well, those are all those all fit into the other stuff. So the reality is you would be assessing those things, because if she's talking to you, she has a level of conscious, she has an airway, she's breathing, and she has a heartbeat because she's talking to you. So your primary survey is done very quickly, maybe even unconsciously. But if she weren't conscious, then you would be checking those things as your first stage of assessing for shock.
Okay. So we just need to rework this a little bit.
But I don't want to put the time in if other people think that that's not a good way to organize this.
No, I think that is the right way to look at it. It's very straightforward, particularly given the environment, such a circumstance you'll be working in. I think it speaks to it perfectly.
Okay.
Yeah, and it fits with the other ways that we look at emergencies. Again, an emergency, you do a set of steps. Yeah.
So I'll help you work on that, Cynthia, to get it kind of organized right.
Okay. And then moving on to surveys. Define a primary survey and explain
That's
its
what we just talked about. So we're going to, yeah.
Okay. Oh, the primary and secondary, it all just kind of rolls in with that. I get it. Okay.
Yeah,
Okay,
that is how you assess. It's not a treatment, it's an assessment.
Okay. So we'll just work on shock a lot together then, Holly.
I'm looking forward to it. I'm going to buy an extra chocolate bar just for it.
Okay. Pulse palpitation. I think I spelled that.
Thumb and wrist. I'm not sure what you mean by that. But we usually call it radial, which is the wrist, the carotid, the brachial, and it's not the inner elbow. It's under where when you make a muscle, it's under that muscle up there on your upper arm there. Temporal pulse, popliteal pulse. The ones we use are carotid, brachial, radial, apical, and femoral.
Yeah, and I don't think you need to define them. Like, we should know this.
Yeah. I feel like this doesn't, I don't know that it needs to be there.
At all?
Well, the reason that I think it's important as something is that this is for an initial, this is for what do they need to learn and know. And so we need to know that they know what a radial pulse is and where you get it, where a carotid, a brachial, a apical, and a femoral, because those are the ones that are most relevant to us in this situation. And then, so temporal goes away and popliteal goes away, and we add in apical and femoral. But also because the part where if you can palpate a carotid pulse, you have at least a systolic of 60, that is a super helpful, important, I think, thing for people to know.
It's
So,
FEMORAL. There you go. Are you there?
Uh-huh.
FEMORAL.
Sorry, I totally heard something else. And what was the other one?
Apical, APICAL.
Okay.
Because if you have somebody going into shock, you're not going to roll them over and try to palpate a thing on the back of their knee. At least I'm not.
Okay.
I mean,
So
maybe
I'll fill in these little, unless you want to give them to me real quick, but I can fill them in.
femoral is in the groin and apical is over the heart.
Over the heart?
Over the heart. I mean, over the apex of the heart, but
Okay, so
ask and include in here those, if you have a palpable pulse at the site, what is the systolic pressure? Or do you think we should not include that in this guideline and ask about it?
I think it's important if they've been taught. I think, like you said, it tells a quick story of that person's perfusion, their ability to perfuse themselves based on where you can find pulse.
where are you at?
I agree.
It's not on here, we would be adding it.
Okay.
And it would be relationship between palpable pulse and systolic blood pressure. And I can help you with this one too. To me, anything that doesn't require equipment much, except maybe a watch, is super valuable.
Can you say it again? Relationship between what?
Between pulse site and systolic pressure, systolic blood pressure. And I'll give you the information. There's what it is later.
Okay. This is another, the dosage guidelines again.
So what comes after this, because what I'm not seeing, and I got rid of my document because we were doing it this way, where does it say what are the 4 steps for basic treatment of shock and the 2 steps for intermediate? Where's that? Like all of this.
Levels of care and resuscitation is 3.13.
3.13.
Explain the 3 levels of care in the resuscitation of a patient in shock: emergent, intermediate, rehabilitative. And then it talks about treatment of shock, positioning.
Yeah,
IV
that's too
therapy.
complex. So all these drugs need to go away for
Yeah,
this.
all of the dosage guidelines stuff is all
Again, okay.
repetitive.
Nothing. But what needs to be more clear in my mind is
I gotta find out where I'm at here. Hang on.
you're in Salem, honey.
I know, I gotta get back to where we were. Okay, so this goes away again.
Yep. And all of that anti-hemorrhagics are not for treatment of shock. The only thing that might be for treatment of shock, because that's primarily how we're legally authorized to use it, is through the IV, but IVs have already been talked about.
Right.
One of our meds and our stuff. So all of that can become gone away. Keep going.
Oh, even more?
Yeah,
Yep.
even more.
Okay, hang on, let me do this.
We don't even have the abilities to start an IV on a newborn at this point, because it's a pretty,
No, not, yeah, right there.
there you go.
Okay. Is that okay? Levels of,
Sure, that's not what we call them. We call them basic, intermediate, and advanced, but sure. We could call it basic / emergent and advanced / rehabilitative. And then for this, those are the 3 levels. So that would be list the 3 levels. But if you want to list the 3 levels and
their components, maybe.
yeah, and their components, or list and define or something like that. And again, I'm happy to work on this with you, Sarinthia, if you want to move on, because it's like there are 4 steps for basic treatment. There are 2 things under intermediate. There's several things under advanced, and we can only do basic and intermediate. We can't do advanced rehabilitative because we
So
don't have.
should we just take that out then?
Oh, they need to be part of people's understanding
Okay,
for sure.
okay,
Things like meds to jumpstart a heart, or meds to paralyze a patient so that you can intubate them, or, prolonged IV therapy with, like there's a lot of things involved, and, it might involve freezing them so that they can, like depending on what you're doing here. So
okay,
all requires at least a paramedic on their way to the hospital, with the end point being the hospital. So,
okay. So we'll work on that, Holly. We're working on, so,
women, define them.
What?
I like the category name.
Pregnant women?
Yeah, it's a fun category. I would have called it special positionings for pregnant women, but.
So are we good there?
I am. It's Vena Cava, Cava, like in vodka.
Kind of like the F versus the TH up there. It's kind of hard to hear. Okay, so IV usage. Explain the reasons for using IV therapy during treatment of shock.
And there are way more than those.
So we need to add more?
Yeah.
Well, because like those are the reasons for using IV therapy, period, right? Like hyperemesis has nothing to do with the treatment of shock.
Well, but the idea, because the way that our law was set up is that these we're using IV to prevent or treat shock. So these are things that could lead to shock. So we are preventing shock from dehydration, from clinical exhaustion, from hyperemesis.
Then we need to change the wording to say that explain the reasons for using IV therapy for prevention of or treatment of shock.
Yeah.
To prevent or treat shock, yes. And so the more, and unless we're limiting this to pregnancy, which I don't think we are, the big reason we actually do it is hemorrhage.
Yeah.
But we also use it, we also are allowed to use it separately from the treatment of shock to administer GBS prophylaxis. And there are other things too, even if you don't know what, and hemorrhage is misspelled, but we'll deal with it.
Yes. I knew there was.
There you go.
So we still need to add more to this list.
Potentially, yeah.
Okay, so I'll put a question mark, and then again, I'll put out your name. Oops.
Oh, so lucky me. This is why I was trying to sign people up earlier, because I had a feeling.
Okay, so the reasons for using.
So that kind of is going to duplicate the one above. So we'll probably combine that into one fun-filled, action-packed joyride.
Perfect. Okay, so 4.2.
So 4.2 is part of what we just were talking about too. So I would get rid of it at this point.
Yeah.
So here's where the beautiful young Desi could probably make us another fine list of supplies, because she's already probably done that up above.
Okay.
Yeah.
You good with that? Okay.
Yep.
Thanks, Desi. Okay. Care of equipment and supplies.
Maybe Des, do you think you could do that one too?
Yeah, you said care of equipment and supplies?
Yeah.
Okay, yeah.
Okay. Okay.
So here, we've already done this, I believe, up above again. And IV solutions don't include any of those anti-hemorrhagics or any of, so. But
So this is completely.
Yeah, so
Go ahead.
everything down to 4.6.
But don't we cover, oh yeah, I see what you mean. So 4.6 we're keeping.
Oops.
Yes.
Okay. My document is spinning, you guys.
It's having a little nervous breakdown.
Uh-oh.
Well, everybody in our office's document is spinning. So hang on just a second. So I cannot touch it because it will lose some of the stuff that we did.
And
Okay,
this-
we're just, you guys, we need to take a 5-minute break.
I was going to say you may need to reboot.
Well, if I mess with it, if I just give it a couple minutes, it'll work its magic.
So being very conscious of the Colleen only has like.
Oh, we're good.
minutes.
Yes. Okay, we're good. Never mind.
I suspect we're not going to get to the test until next meeting.
You know, Holly, when we talked about having that 3rd meeting or 4th meeting, I just was like, no, we're not going to need.
I didn't say fourth meeting. I didn't say 4th meeting. I thought if we got through the competencies this time, and then everybody could review them ahead of time and we could just focus on any concerns people have with them at the beginning of next time, then go through the skills exam and get that done, and then use the last part of that meeting and maybe the 3rd meeting to decide which questions we want to use on the written exam. Based on what I've submitted, what hopefully Julia has submitted, and people kind of prioritizing what they think is most important to ask on a written exam, and figuring out how long a written exam we want, which is something people could think about now. I'm thinking somewhere between 100 and 150 questions, all multiple choice type or true false, that can be graded by the software that Cynthia is recommending that we use, that the state uses. But maybe think about that ahead of time so we can set up some ideas about what is most important to ask within the context of 100 or 150 questions. How long are most other written exams, Cynthia, for your other things?
It really just depends on the content areas that you need to ask questions on. So really, the content defines the bank.
Yeah.
So if you have 50 subject areas and each of those subject areas have 2 subsets, then you're going to have a 100-question test. But if you only have, 5 areas with, 2 areas subsets to ask, then you're only going to have a 10-question exam. It really just is everything that you need to ask. What is important in these competencies?
Well, part of that is going to be, some of this is being assessed by preceptors and teachers and other contexts. So it's something that we just need to think about, though, because if we were asked questions, there may be whole areas in here that we don't ask a question about, or we only ask one, even though there's a lot to ask. Or we word the question in such a way that that we're covering more information. Like here, I'm thinking of, the four treatments of basic shock. We could list 3 things that are correct and 1 thing that is incorrect, and they have to identify the incorrect one, that kind of thing. So
we do have rules in regards to writing questions. Like we don't write true and false questions.
Right.
And then you don't ever want to do the negative, which are not. So as these questions come in, I'll write them according to the rules. I just need to get the content, the basic questions from you guys. Does that make sense, Holly?
Yeah, I see other people nodding up and down too, so that's encouraging. But anyway, if we could use the 3rd meeting to look at that, then maybe we can be done in 2 more meetings.
Yeah, I think so. I think we definitely can. Okay, so 4.6. Explain the differences between. Am I going to work with you on this one, Holly?
Sure.
No.
Yep.
Okay. Rectical. So
I think on 4.7, they're fluids that are used for IVs, but they're not. Do people feel okay calling them IV fluids when we administer them rectally, or how should we?
No, IV
I would
describes,
just take out IV.
IV describes the way you're administering it. So that's a rectal administration, not, yeah, no, that's bad.
Yeah, I kind of
Explain
might
and
feel
describe rectal administration of fluid.
right.
So say that again.
Just take out IV.
Take out IV, yeah.
Okay. Same with this one.
No. Here we want to explain the procedure for administering fluids IV. See, the first question includes procedure by saying describe rectal administration. So that includes procedure. So you could say and explain and describe IV administration of fluids, and that would have the same structure.
So does that cause them to go all the way back to find a site, cleanse the site?
Right.
Yeah, good point.
Because rectal administration is, we're using often IV, fluids that are used for IV, but we're administering them rectally for whatever reason. But sometimes we're just using a Fleet's enema just to plump up the veins a little bit.
So what would my answers be here?
So maybe what we want to do is explain the use of rectal administration of IV of fluids for IV administration or something like that. Is that maybe why this is here? Does that make sense?
No, it's like an alternative, right? Because you can administer fluids and medication rectally. So
Yes, you can.
if you can't, they can't get an IV site or whatever. So it's not, they're not doing it to be able to place an IV. They're doing it in lieu of an IV.
Well, it's
Right.
both. I also use it in order to be able to place an IV on veins that are, because she's bled out so much, she doesn't have much oomph to her veins. So I push a little fluid that way, and then I can put the IV in more easily. So it's both. So
Colin,
maybe we've covered rectal administration under routes of administration. The fact is, you don't have to use IV fluid. You could use any kind of fluid. It's not legend necessarily a drug that you're using.
Well, so I'm looking, I want to go back to what Greg said, is that if in 4.8, are we just then circling all the way back? Like we've already kind of talked to, right? Didn't this already happen earlier? And then if you want to keep it there, then, and also have it with the rectal, then it should be administration of fluids, period, because
Right.
we're not just
Did
talking
we
about.
cover the steps to administer IV fluids already?
No, I don't think we have covered that yet,
We have
actually.
either.
Yeah, it's just listed in routes of administration, but
Yeah,
I don't think it's been
explain the
covered,
steps.
not steps.
So I think we need to keep 4.8, and I don't think we need 4.7, because the routes of administration should cover rectal.
Well,
And
but
that's
I
all
mean, I
we
do
need to
think
say.
we need 4.7 because administering cytotech rectally is not the same as administering fluids rectally. And
But this section is on IV.
right. So like under routes, like,
So that would go under cytotech, routes of administration, when we talk about cytotech, and then rectal is under routes of administration, but this is about administering IV fluids. And so I think we don't need rectal because they're not intravenous. Unless you're puncturing a hemorrhoid, I guess, but that doesn't sound like a good idea.
So
that's
rectal
true, but I think it's lumped in here because people spike a bag, cut off the end of the tubing, and administer those fluids rectally. And so it gets lumped under IV fluids because like we're making a distinction between like they're not IV fluids if they're not going into the vein, but like most people, if you give them a bag of fluid, whether it's going into the vein or in the rectum, are going to think IV fluid, right?
So then we should call this treatment of shock via rectal administration of fluids.
Colleen, did you have something to say?
Well, I mean, I wonder if just saying administration of fluids and then you have a rectal route and then you have an IV route.
Yeah, I like that. And maybe having the IV listed first and then the rectal as an alternative. And you can differentiate between using bagged fluids and an enema.
I like that, Desi.
So Des, would you mind looking over this section with Cerinthia then?
Yeah,
Because you have it really clear in your head.
yeah. I've done this a few times.
Yeah, I've done it a lot of times, but it's more, I'm trying to wrap my brain around the way we're organizing it. And I think you have that more clear in your head.
Yeah. I'm thinking of like other informed choice documents or other ways where we're going to start with the most standard method and then list an alternative. And using rectal fluids is not the first go-to most of the time. So.
Okay, so we will do it this way. The IV administration of fluids first and the rectal administration of fluids. And then Desi, you'll work on this section with me.
Yeah.
Perfect. Okay. 4.9.
That doesn't belong here.
So it just goes away altogether?
Yes.
Yeah, because we covered it under dosage and administration, like
Okay.
when they're way up at the top at 1.4.
Okay, IV flow.
Yes, all of
here.
those are important.
But
I can
4.10
help you
needs to
with
be more
those with
specific.
answers that I have for
Yeah.
these, if you want.
Julia, what did you say, hon?
It sounds like Holly's got it covered. It just needs to be a little bit more specific because the flow rate varies depending on what you're using the IV for.
Right.
I will put you here, Holly. Okay.
And what
We're back to dosage guidelines again.
So do we have GBS as its own separate section in this, Cerinthia, or are we working these in through the various sections? Like we put the drugs for IV prophylaxis up in the drug section, as I recall, correct?
Mhm.
It's all,
Yeah.
yes.
So then we need to have a section on IV administration for treatment of shock. We need to distinguish that from IV administration for administering prophylactic antibiotics for GBS, because that's a real different everything, which we can talk about when we do it. So don't worry about it now. But that what you just said, Julia, reminded me of that. Like this section has so far mostly been about, we need to start an IV because she's in shock, not, oh, she's in early labor and we need to get, an IV. It's different sites, it's different everything. So
So maybe under administration of fluids, we could have 4.9, which is about like administration of IV fluids for 4.8 could be like for shock and 4.9 could be for GBS prophylaxis.
yeah, that's what I'm thinking.
Okay,
Mm-hmm.
so what, say it again?
So 4.8, explain and describe the procedure of administration of IV fluids for shock.
So on what's now 4.7, Cerinthia?
Oh, okay.
I'm sorry. I'm looking at my computer, which has the old one. Sorry.
Yeah, that's why I stopped using it, because things got changed.
Okay, so explain and describe the,
IV administration of fluids for shock.
okay,
Or to prevent and treat shock or treat
Right.
shock. And then the same thing, rectal administration of fluids.
To treat or prevent shock.
okay, and then are
And
we
then we
adding
need
a
a
new one?
4.9. And then that will be Explain and describe the IV administration of fluids. For GBS prophylaxis.
Did you say per or for?
Or
Can't even type anymore.
I've done that so many
What?
times. It's like, what is wrong with my fingers?
I have hit G 5 times. I don't know why it's not doing.
That's
Da,
a
da, 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 da. I know what to add.
Yeah.
And I'm happy to work on that as well, but I would appreciate maybe someone else who's taught that, either Holly or Julia, maybe to help me with that.
Julia, can I add your name?
Sure.
Perfect.
Awesome. I'm feeling excited and good about this. We're kind of getting there.
Mm-hmm. And what time do you need to leave, Colleen?
She needs to leave by 1:30, she said, which is in 12 minutes, but we have to give her pee time.
Okay. So we took 4.9 out. So IV flow rates.
We already went
Yep,
over this.
Holly. Yep.
Yeah, we already went over this, Cynthia. There's my little name.
Oh, sorry. Yes, it is. Sorry.
And we got rid of all of this
Okay. So dosage guidelines again here we're getting rid of.
because we already covered all that.
Mm-hmm.
So all the way down to like 4.15 with dangers and risks.
Oh, okay. Okay.
Keep it going.
Okay. So do I leave the dangers and risks though, right?
Yes.
Yes.
Mhm.
Okay.
Does anybody want to work on that?
How about Greg?
can
I
do that.
haven't heard your name in a while.
Oh yeah. Mhm.
Put me down.
Now, the timeline for getting these back to you, is this, like, when do you need these things?
Well, let's see if we're going to meet on October 6th. Let me look at the calendar here.
We have 5 weeks to get this done.
Well, I'm headed to Portugal on Sunday for 2 weeks, so I want
I'm so sad for you. Boo-hoo.
Right.
So what I would like to do is I would like to reformat all the numbering and get it to look good again. So that way, when I email you and I say this is the 4.2, 4.3, 4 point whatever is the section I would like to work with you on. Can you provide me? And I'll get that done by say next week. And then if you could take a couple weeks to work on that and then get it back to me, will that all work for you?
Sounds good.
Are we
And
close
then-
to the end? I'm very excited to see that are we close to the end?
I think so.
Hold on, back up.
No, we have suturing to go through.
Okay.
So we
have till 2. So do you trust us, Colleen, if you can review it when you get a minute?
Trust you.
I don't know. Sometimes I don't think you should trust me, but maybe not about this. There may be other things, like don't leave me around unattended chocolate. That could be very iffy.
Uh-huh.
right. Okay, so 4.17.
Well, equipment safety and patient safety aren't the 3 aspects of IV fluid to check. It's clarity, expiration date, and appropriate appropriate medication is right.
Oh, oops.
Appropriate medication, clarity, and expiration date. And those things will help keep the patient safe and
Okay. 4.18.
administering or changing an IV, or is this this is just for an IV? Hand hygiene, sterile barriers, optimal sites. Sure.
Okay. Practical application. So this is we talked about removing we don't need to list anything here because it's going to refer to the skills exams.
Except I'm not sure, I have never had anybody in my LD&D class on the test have the model lie down, blah, 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 in that first one.
Yeah.
Do you do that, Julia?
No.
Yeah, I'm
So
more
it needs to
focused
be on
on
a,
start a frickin' IV.
so it needs to be on a mannequin?
Well, the question is, do we want to include it in our skills testing? And in my mind, if they can tell us what to do, they should be able to lay them down, raise their feet, not give them anything by mouth,
Cover them with a blanket.
cover them lightly if necessary.
Yeah.
Like that. Those are pretty.
So it should say explain or describe, not demonstrate.
Yeah, but we've already done that up above.
Okay, so we could just take this out.
I think so.
Yeah.
But demonstrate on a mannequin appropriate steps for administering an IV, yes. And I would say IV for treatment of shock or for prevention and treatment of shock, because they also need to show us the different site and the different technique, including a lock for the prophylactic DBS prophylaxis.
Yeah.
Do I need to add something here? Do I need a 4.223?
What I
Well,
would
so
do is, go ahead.
Oh, I was going to say, so what I would do is on 4.22, I would add a comma and, and include in at least 2 separate sites and including a saline lock.
So are we going to require live model starts in this exam?
We need, and include what? I'm sorry, Julia?
And
A saline-
including
a
a
lock.
saline lock.
Okay, well, I don't know. This was what was on the previous LD&D, so like this
Yeah,
one didn't
I mean,
even
that's the
have.
bar right now.
Huh?
I said that's the bar right now is 4 successful starts.
So what I would prefer is to have them submit, in order to be able to do the skills test, something that shows that they have done 4 successful IVs, rather than having us test them for 4 successful IVs, which would require 4 live models. Do you see what I'm saying? Like, if I would prefer to have it where, however many we think they need to have demonstrated they can do, then successfully having them signed off on by whoever, they one successful IV start of a live AC site for shock, and then on a mannequin arm do the lock on the the arm or the hand for the prophylaxis, and do that on a mannequin arm. That way they don't need 2 separate models or 6 models or 4 models or whatever. It's going to be less expensive and more straightforward. So we could have, as a punch your ticket to be able to take your skills test, you have to show that you have started 4 IVs. What do you think about that?
But isn't that what we're doing here, Holly, is we're putting, this is the competencies. We're stating you have to do this with your preceptor before you take a skills exam. So if that's what our competency is, that you must complete on 4 individuals all these things, then that's what we need to say.
Sure, but the addition is, and you need to be able to document it before you sit
Siri
through.
has a question for who to look at. Who's going to verify?
Whoever's doing the
The
skills
person doing the
test,
skills testing.
who is not the person who taught them, right? It's a separate person.
Mhm.
It's not gonna be the office, I guess is the question.
Yeah, no.
No, we're not asking you, Sarinthia, or you.
No, I don't, I
Because somebody could put down 4 in and we're never gonna know if it really happened.
Okay, so for this section, this is where the competency is. They must complete this. And
I
then
would
you,
add at least 4 IVs. So add at least.
on which one, 422?
Yeah.
Oh, I'm on okay.
Of at least 4.
Back up a little bit.
Of,
See the 4? See the IV? See the 4?
just of at
You're
least.
tired, honey.
I know,
Our brains are starting to
well,
blow
it's
up.
just because I'm looking and typing and trying to, it just,
Yeah, it's a
After
lot.
a couple hours, it gets,
Or in this
okay.
case, 3.5.
So on a live model, correct administration and discontinuation of at least 4 IVs
In at least 2 separate sites.
at least
In
at least 2 separate sites and include a saline lock.
Okay, so after live model, comma, put the word demonstrate. There you go.
Okay, so what about on these on 4.21? So we don't need. No,
No.
okay.
That's fine.
So 4.2 is fine. It's a mannequin. 4.21 does not specify whether it's live or on a mannequin.
It doesn't need to be.
It's either or.
I think so.
Yeah, for sure.
So,
Not what I would consider a super advanced skill,
okay.
but important to be able to do for sure. So if this is just stuff that they're able to do that we're not going to test them over, then we could keep 4.19, right?
Yeah, this is just what they need to learn.
Right. So then we don't have to say on a mannequin or so you for 4.2 say on a mannequin or live model or live person or
On any of it?
yeah. Well, no, on 4.22, we want them to have done it on it is very easy to start IVs on mannequin arms. First of
Yes.
all, the veins look like the super highway of all time, you know. It's like with little signs that say insert needle here.
And they never run away from you.
They never run away. They don't roll. They don't squeal. They don't cry. They're just being
out. It's great.
Yeah, it's awesome. So
this is,
what we're saying is before they take these tests, they actually have to have done this at least 4 times. Of course, you know, my feeling on this is it needs to be 24 times, but before we set them loose on the world. But I understand that that's not realistic in what we're trying to accomplish. So I'm being a big girl. I'm adulting and going with 4 because I'm an adult. But
thank you, Holly.
Putting it out there that really, truly, if they've only done 4, that might not be enough for them to be completely competent. In fact, I would say it's not enough for them to be completely competent. But
do we want to increase that number then?
I think the consensus was not to, because it could take people a really long time to get 6 or 8, unless they're in a school or in a workshop or in a program to get that many actual live IVs.
Or their preceptor's willing to be a pincushion.
Or they're, with somebody also there to supervise in case their preceptor goes into shock, because sometimes that frickin' happens.
Okay, so we are going to take a minute and thank you, Colleen, for your time today. And we know you have to go, so we want to be respectful of that.
Thank you all, and I'll see you in October.
Good luck this afternoon. Fingers crossed you get a nice, tolerant, helpful exchange of information.
I just need them to do what I tell them, but we'll see how it goes.
That works so well in medical setting.
Yeah, exactly. All
So
right,
well. Take care, love.
Thank you. Thank you very much. Okay, you guys, I need to take a quick few minutes, run down the hall, and then we'll come back and finalize this section and go over 5.0 if that's okay with y'all.
That's great. 5 minutes, are we saying?
How about 7?
7 minutes. You got it.
Thank you. I'll be right back.